So let us start our class. I think it's recording. So first question. So what is this question? Let us see. Uh, so first thing what I will say before attempting your NEET papers, whenever the examiner is giving a question, certain question, when you are reading the question, please categorize which system it belongs to. In that system, which topic it belongs to. If you do that thing, 50% of your effort is completed. So let us see this thing. This question examiner is asking: a 63-year-old man presents with rigidity and bradykinesia and also gait imbalance. So what is this thing? This question is about movement disorders of the brain. Okay, in the movement disorders, rigidity bradykinesia means it's a hypokinetic movement disorders. Hypokinetic movement disorders. Okay, and again, apart from what is saying, his patient is rigidity, bradykinesia, and gait imbalance. That means patient is having some Parkinsonism features, right? You can agree this thing. For this, no need to study Harrison. We are seeing so many patients in OPD. Parkinsonism features. Patient is having rigidity, patient is having bradykinesia, and patient is having gait instability. That means it's a Parkinsonism features. Apart from that, what examiner is asking, I'll change the color. So examiner is asking about symptomatic postural hypotension and also urinary urgency. What does it indicate? Symptomatic postural hypotension, that's orthostatic hypotension, and urinary urgency indicates autonomic dysfunction. Accepted? Autonomic dysfunction. Okay, and there is minimal tremor. Again, one more color I'm using. There is a minimal tremor. Even though it is a Parkinsonism, but tremors are less, and then a poor levodopa response. Okay, the poor usually Parkinsonism will response to levodopa, but there is a poor levodopa response. These 2 points indicates it's a atypical Parkinsonism. Atypical Parkinsonism. Right? Now, what is the most likely diagnosis? This is a simple question they asked. So first of all, they're discussing about the movement disorders. In the movement disorder, they're asking about hypokinetic movement disorders because the patient, they have rigidity, bradykinesia, and gait instability. So it is a Parkinsonism symptoms are there, plus patient is having some autonomic dysfunction in the form of urinary dysfunction and also orthostatic hypotension, right? Apart from that, patient is having minimal tremor and poor levodopa response. So what is the most likely diagnosis? Can anyone say the diagnosis? Yeah, someone answered already. Right. Okay, let us see. Now, based on these things, let us see. I just want to mention you, when you see this hypokinetic movement disorders, when you take the hypokinetic movement disorders, MD is hypokinetic movement disorders. I can divide hypokinetic movement disorders as two things. One is called as your typically what you see in OPDs, that is your Parkinsonism, right? And other is called as Parkinson plus syndrome. Parkinson plus syndromes. Simple, right? When you see the Parkinson, what is the thing is, you already know Parkinson has 4 features. One is tremor, other is your rigidity, other is your akinesia, other is your postural instability. The trap symptoms we all study from the UG also. Tremor is pill rolling tremor, rigidity is cogwheel rigidity, bradykinesia, and postural instability. All these things are there. Important point in this thing is all these things are asymmetrical. Very important. In Parkinsonism, asymmetry is the rule. Okay, asymmetry is the rule. It always starts from one hand, then progress to right hand. It always asymmetrical. Even though it progress to right hand, if both hands are there also, one hand is greater than other hand. So for example, if a patient has developed some tremors in the right hand, over the few years he will develop tremors on the left hand also, but right hand tremors are more when compared to the left hand. That is called as asymmetry. Asymmetry is the rule. If there is no asymmetry, there is no Parkinsonism. Right? So in this, one more important thing is this Parkinsonism usually it occurs because of your substantia nigra degeneration. We know already. Okay, substantia nigra is striatonigral fibers. That means the fibers coming from substantia nigra to the striatum. Striatum is your chordatum, putamen is striatum. So these are dopaminergic fibers. Dopaminergic fibers. Okay, these things are lost in Parkinsonism. We all know. So that is why the treatment of choice is always levodopa. Okay, an important thing is it's a very good response. If you give levodopa to the person will have very good response. It's very good response to the levodopa. That is the typical features of Parkinsonism. So many things are there, but basic things we are needing. So Parkinsonism, it's a degenerative disease because happens because of your striatonigral degeneration. That means the fibers coming from corpus striatum to the substantia nigra, they are dopaminergic fibers. Because dopamine is lost, patient will have tremors, rigidity, akinesia, and postural instability. Always asymmetry is the rule. Symmetry it happens, it's never a Parkinson disease. Very very important, right? So because it's a dopamine loss, treatment is always levodopa, and it's a good response to levodopa. There are many other drugs with patient has tremors. You have pacity and triaxiphenyl, MAO inhibitors. Okay, all these things we'll discuss those things later. But when coming to Parkinson plus syndrome, very very important here. When coming to Parkinson plus syndrome, right? What is going to happen here in Parkinson plus syndrome? The patient will have Parkinsonism features, right? Parkinsonism features. So what are the Parkinsonism features? Patient will have rigidity, patient will have akinesia, but patient will have less tremors. Not so frequent as seen in case of Parkinson. They have less tremors. Very important, right? And very very important is they're always symmetrical. Very important. They're always symmetrical. Okay, they are never asymmetrical. They always comes in both hands, right? Another important thing is they have poor response to levodopa. Even though you give levodopa, they won't respond. So that is why their survival is very less. Very important thing, right? So Parkinson plus features very important. The patient will have Parkinsonism features, but not completely all four cardinal symptoms. Rigidity and akinesia is there, but tremors are very less frequent. But they are always symmetrical. One hand rigidity, other hand is also rigidity, and they have poor response to levodopa. That's why their survival is very very less, right? Simple thing. One is Parkinson's, other is Parkinson plus syndrome. Right? So when you see this Parkinson plus syndrome, what I want to say, when you take this Parkinson plus syndrome, okay, definitely you have three types. Very very important. They have three types. All these things we studied before only. Just we are summarizing all these things. One is your progressive supranuclear palsy. Very important. Other is your multiple system atrophy. Okay, and other is your what is called your corticobasal degeneration. Three things: progressive supranuclear palsy, multiple system atrophy, and corticobasal degeneration. Right? These are your Parkinson plus syndromes. So we discussed about Parkinson plus syndromes. They have Parkinson's features, but tremors are less frequent, but they are symmetrical and poor response to levodopa. When you see this thing, they have three categories. One is progressive supranuclear palsy, multiple system atrophy, and corticobasal degeneration. Right? Let us see one by one. Very easy. We'll discuss these things. First, come to progressive supranuclear palsy. What is going to happen here? The patient will have degeneration in the midbrain plus substantia nigra. The patient will have degeneration in the midbrain and substantia nigra. Right? So what is the main characteristic of this patient? Main thing is supranuclear gaze palsy. Very very important. Supranuclear gaze palsy. That means his vertical gaze is lost. His vertical gaze is affected. In this vertical gaze, mainly downward gaze is affected more. Downward gaze than upward. This is the previous year NEET SS question. Downward gaze is affected more than the upward gaze, so that he cannot see down. He always sees up. When you see his eyes, he's always staring eyes, and when he's getting down the steps and all, still he's seeing up only. So there's more frequent falls are there and more frequent gait instability is there. Right? So midbrain plus substantia nigra is lost. So supranuclear gaze palsy, especially vertical gaze is affected, and in that downward gaze is affected more than the upward gaze. Very important. Right? Now, when you see the MRI brain, what is going to happen in MRI brain? Definitely, as I said, midbrain is atrophy. There is atrophy of midbrain. Okay, and that is seen as what is called as hummingbird sign. I will let you know. I will show you the image also. No worry. This is called hummingbird sign. This is again previous year NEET question. It's a hummingbird sign. Same questions will be repeated here and there. Okay, so hummingbird sign in MRI is seen in progressive palsy. In 1 year, they kept image of this thing. I will show you the image. Right? Right, hummingbird sign. When you see this biopsy, when you do the brain biopsy in this thing, what is going to happen is, right, they have some tau bodies, okay, and plus astrocytes are there. These astrocytes are tufted. They are all tufted. Very important. Tufted astrocytes are there. Simple. Right? It's a progressive supranuclear palsy. Midbrain and substantia nigra degeneration is there. Especially main important symptom is supranuclear gaze palsy. They cannot, vertical movements are affected, especially downward movement is affected, so they cannot see the down, always staring eyes. If you do MRI brain, there is a midbrain atrophy which looks as hummingbird sign. When you do the biopsy, you have tau bodies and also astrocytes. They are arranged in tufted pattern. Okay, okay, right. Let us see about this multiple system atrophy. Right. So what is this multiple system atrophy? The name itself, multiple system atrophy, is there. Right. In this, your cerebellum plus inferior olivary nucleus is also involved. Okay. So especially very important thing. This is the only Parkinson plus syndrome which have autonomic features. Very important. Autonomic features. That means an orthostatic hypotension, excessive sweating, urinary urgency, constipation. All these things will happen in multiple system atrophy. Right? In this multiple system atrophy, if there is cerebellum is degenerated, that is called as MSA-C. If there is Parkinson features are there more, that is called as MSA-P. Simple. Right? When you do the MRI brain, what is going to happen here in MRI brain? If cerebellum is there, we have hot cross bun sign. I will show you these things. Hot cross bun sign. Okay. In MSA-P, that is putamen is lost, we will have putaminal ring sign. All these things they asked in previous things. Okay. What is the MRI finding in multiple system atrophy? In the case of MSA-C, you have hot cross bun sign. In the case of MSA-P, you will have putaminal ring sign. I will show you those things. Yeah, I will show you the images. Right? In multiple system atrophy, if you do the brain biopsy, what you will see here also, you will see the same things. This astrocytes also, but astrocytes are arranged in plaques. Plaque sites are astrocytes. Very important. This was the question they asked. When you do the brain biopsy, how do you differentiate PSP and MSA? PSP will have tufted astrocytes. MSA will have astrocytes arranged in plaques. Right? And the last is nothing but corticobasal degeneration. Very important here. Okay. So corticobasal degeneration, name itself means cortico and basal degeneration. That means cortex is involved and basal ganglia is involved. And the cortex is very important. It is always frontoparietal cortex. Frontoparietal cortex. It spares occipital. Very important. It's excellent. Number of times repeated question. The corticobasal degeneration, cortex is degenerated, basal ganglia degenerated, and the cortex frontoparietal degeneration is there, but spares occipital. Very important. Which lobe is spared in the case of corticobasal degeneration? Is always occipital. Right? So that's why patient will have cortical signs like apraxia, agnosia, all these things, and basal like Parkinson's features also. Simple. Very important. That's it. So these are very important. These things you have to remember. So let us see the images I will show you here. When you see the first image, this one, when is the first image? I think everyone can see the image. So this is the sagittal section of the brain. When you see, this is your brainstem. What is the brainstem? This is your completely your brainstem. Okay. So this part is your midbrain. This is your pons, and this is your medulla. Right. And note down here. This is midbrain. This is pons, and this is medulla. When you see the midbrain is very much atrophied, very much thin, right? So when compared to the pons, this entire is the pons, and this is the midbrain is very much thin. So this way it's looking as a hummingbird sign. This is hummingbird sign. This is hummingbird sign, right? So midbrain atrophy is more than the pontine atrophy. So you will see as a midbrain is very small, and that is what is called as hummingbird sign. I'll just draw image. This is your midbrain, but this is entirely is the pons. So pons is the midbrain is there. So it's called hummingbird sign. I think everyone can appreciate, right? Now let us see what is this sign. So this is again your cerebellum. This is your cerebellum. Okay. If you see this thing, this is the pons. This is entirely is pons. Okay. You have two hyperintensities. I'll change one more color again. You have two hyperintensities here. One is vertical and other is horizontal. Right. This is vertical and this is horizontal. So this appears a hot cross bun appearance. Very important. This you see in case of multiple system atrophy C. Right. And what is this image? The third image, very important here. If you see third image here, this is your coronal section of the brain. When you see this is your internal capsule, you can see this internal capsule. Okay, this is your caudate nucleus, and this is your lentiform nucleus and all. Okay, when you see on the right side, there is some hyperintensity. That is what is called as putaminal hyperintensity, putaminal rim sign. This is in a case of MSAP, simple, and this is in a case of progressive frontal palsy. Right. So this is a topic they asked, very important topic. So few things very important. So Parkinson and Parkinson plus syndrome. Parkinson always symmetrical. You have trap features, good response to levodopa, they have good survival. But Parkinson plus, they are always asymmetrical. They have rigidity, akinesia, but tremors are less. Right. and their poor response level upon the survival is very, very less. When come to Parkinson plus syndrome, you have three features. One is progressive supranuclear palsy, multiple system atrophy, and corticobasal degeneration. Right? Patient has a Parkinson features along with the supranuclear gaze palsy, that is progressive supranuclear palsy. When you see the brain, MRI brain, midbrain is degenerated, you will have hummingbird sign, very important. When you see the biopsy, you will have astrocytes arranged in tufts. But when you see multiple system atrophy, in this cerebellum is also involved, they have ataxia or Parkinson. If it's ataxia, MSA-C. If it's Parkinson, they have MSA-P. MSA-C, MRI brain, you will see what is called hot cross bun sign. In the case of MSA-P, you will see what's called putaminal ring sign. When you do the biopsy, you will have plaques in astrocytes and plaques. And corticobasal degeneration, patient has degeneration both in the cortex and the basal ganglia. The only question they will ask is, in the cortex, the frontoparietal degeneration is more when compared to the occipit. There is always sparing of the occipital lobe. Right? So now let us come back to the question. What the question asked? So the patient has 63-year-old man, rigidity, bradykinesia, yes, is hypokinetic disorder, Parkinson's symptoms, yes, Parkinsonism, symptomatic postal hypotension and urinary urgency, that is autonomic dysfunction is there. Along with this, patient has a minimal tremor and poor levodopa response. That means Parkinson plus syndrome, which has autonomic symptoms. That's what the question they're asking. Right? Your answer is your multiple system atrophy. Clear? Very simple. So simply they asked, what is the Parkinson plus syndrome with autonomic features? We discussed already. The thing which has autonomic features is your multiple system atrophy. Right? Clear? Right. So this is not a progressive palsy because patient should have a gaze problems. It's not this thing. Parkinsonism, patient will have good response to levodopa. They should poor response. It's also not a thing. Corticobasal degeneration, again, the patient will have cortical signs also. So this is not the thing. So answer is multiple system atrophy. Clear? Any doubts? Any doubts? Let's move on to the next question. It's a very simple thing. We are covering questions from different systems. It's not only complete neurology or something. Right. So this was again recent NEET SS 2025 paper. This was a simple question they asked. Let us see what is the thing. A 42-year-old man presents recurrent nocturnal syncope. The patient has a recurrent syncope. His ECG is shown below. We'll see what is ECG. But without knowing ECG also, can we answer or not, we'll see. His elder brother had sudden cardiac death during sleep at age 38. The patient had a family history of sudden cardiac death. So what is the single most appropriate intervention to prevent sudden cardiac death? Right? Simple thing they're asking. The patient had a syncope, right? The patient had a family history of sudden death, right? Then what is the single best intervention you have to do? And they gave an ECG. We don't know what is the ECG. But simply I'm saying, so any patient has sudden cardiac death and is also having recurrent syncopes and all, definitely patient is developing some VTs. You have to prevent further development of VTs. To prevent further development of VTs, you have to give implantable cardiac defibrillator, ICD implantation. No need to see ECG also, but very important we have to see the ECG because the thing which was asked in this session, next time they'll ask about identify the ECG also in the next questions. That's why you have to know about ECG. Right? Let us see this ECG. What is ECG? Right. So let us see this ECG. If you see ECG, when you see the V1, V2 and V3, let me change the color. When you see the V1, V2, V3, you have some ST elevation is there. And ST elevation is coving type of ST elevation. It is called coving type of ST elevation, right? This is coving type of ST elevation. Along with the T inversion is there. It's called T inversion is there. Right? Only in V1, V2, V3, this coving type of ST elevation along with the T inversion, this is called as Brugada pattern. This is called Brugada pattern. Right? And this suggests of your Brugada syndrome. Right? So let us see. So this is the question I am saying you. Same ECG I kept. So same V1, V2 and V3, they have coving type ST elevation with coving type with T inversion. Coving type with T inversion. This is called as Brugada syndrome. So what is this Brugada again? This is a sodium channelopathy. Sodium channelopathy. The patient has a problems in the sodium channels. So because the sodium channels are problems there, suddenly they will trigger ventricular tachycardia and the patient can have sudden cardiac death. Very important. So what you can do, you have to prevent this sudden cardiac death. That means you have to prevent ventricular tachycardia. That means you have to put one implantable cardiac defibrillator. No drugs can help in preventing your ventricular tachycardia. Right? So how to diagnose Brugada syndrome? Very, very important. The only diagnosis you have to do the ECG. In the ECG, you will see this coving type of ST elevations from V1 to V3 along with T inversion. So that's very, very diagnostic of the things. Right? So this is what they said. The ECG, how will you diagnose Brugada is the patient should have ECG findings along with any one of these things. The patient, what are those things? The patient may get episode of syncope. The patient may get episode of ventricular tachycardia. The patient may had a family history of sudden cardiac death. All these things are there. Suddenly, if you see in the casualty, the patient took an ECG and ECG is showing this Brugada pattern, then if you want to diagnose it as Brugada syndrome or not, the patient should have at least one of these things. The patient should have documented VF or VT, right? The patient should have family history of sudden cardiac death, or patient should have code type ECG in family members also, or patient should have, when you do ultrafiltration study, the patient should get VT, and patient has nocturnal agonal respiration. Any of these symptoms are there, along with this thing, this code ST elevation with reinversion is there, then you can call it as a Brugada syndrome. Right? Simple. So one more thing in Brugada they're asking is that mainly this is the only Brugada that was approved. That is approved. When you see this thing, definitely you will diagnose it as Brugada. But there are two other patterns which you can diagnose as Brugada also. What are the two patterns? This is called type 1 ECG. As I said, the coding ST elevation with T inversion. It's a type 1. That's a characteristic Brugada pattern. If you see this thing, no more doubt, you can label him as a Brugada syndrome. But there are two other entities also which are really highly suspicious. One is called as saddle. This is the saddle. We can see the saddle. Okay, the saddle shape ST elevation. The saddle shape ST elevation V1 to V3. That also you can take it as a Brugada pattern. But along with this, patient should have a definite symptoms and all. And the third is thing, either saddle shape or coving, but less than 2 mm. Less than 2 mm. That is called as type 3 Brugada pattern. Right? So Brugada patterns, you have three patterns, type 1, type 2, type 3, and type 1 is the code ST elevation with T inversion of more than 2 mm, very important. Okay, and type 2, it's just only have a saddle back, saddle shape ST elevation. And type 3, either A or B, but they should have less than 2 mm, that is called as type 3. Especially this type 1 is the one which is characteristically approved. If there is thick, you will diagnose as Brugada, but when type 2 and type 3 is there, you need to do further evaluation before diagnosing it as a Brugada syndrome. Right? Simple. Right. Apart from this, one more ECG you have to learn, because when they ask ECG, sudden cardiac death ECG, apart from this Brugada, you have to know about one more ECG. Let us see this ECG. What is the ECG in this? Right. So now this time they asked about Brugada syndrome because it's causing sudden cardiac death. There are one or two ECGs which can also cause sudden cardiac death. So that you have to remember here. When you see this ECG, what is ECG? Abnormality, anyone can say? Right. So if you see here, in V1, V2 and V3, right, after QRS, there is some more small wave is there. This is a small wave. That is called as epsilon wave. That is what is called as epsilon wave. At the end of the QRS complex, again you will have some small depolarization. That is called as epsilon wave. Okay. Apart from that, if you see like incomplete bundle branch block, this is called incomplete bundle branch block. Okay. This you see in case of arrhythmogenic right ventricular hypertrophic disease. Arrhythmogenic right ventricular hypertrophic disease. So how do you diagnose this thing? ARVH. What is going to happen in this thing? In this arrhythmogenic right ventricular dysplasia, ARVD, arrhythmogenic right dysplasia. So what is going to happen? The right ventricle myocardium is replaced by the fat. Okay. So because myocardium, right ventricle myocardium is replaced by fat, right ventricle depolarization is slow when compared to the left ventricle. Okay, so that is the reason even after completing the QRS complex, small depolarization, there is a depolarization right ventricle. Okay, that you see is called epsilon wave, and that is the reason your depolarization duration is prolonged. So you will have some incomplete bundle branch block pattern, and also you have T inversions. Right. So this is what we discussed in the other points here. Let us see these things. Right. So T wave inversion right precordial it's V1 to V3. Right, epsilon wave, that is the most specific that you see in case of V1 after QRS, some small deflection, that is your epsilon wave. Right, and again localized QRS widening, only at that part QRS widening is there, and also sometimes ventricular ectopy of LVV morphology. Anything is there, you can diagnose arrhythmogenic right ventricular dysplasia. Right, so anyone asking about sudden cardiac death, you have to remember three ECGs. One is Brugada pattern, other is arrhythmogenic right ventricular dysplasia, other is hypertrophic cardiomyopathy. And you all know what is hypertrophic cardiomyopathy. In young adults, suddenly the athletes and all, they're running suddenly because of death. When you do ECG, they'll have T inversions. Deep T inversions are there. That is because of your LVH and all. Okay, that also you have to diagnose. When you go to casualty, when you take the ECG of any person, if you are seeing these three patterns like deep T inversions, like hypertrophic cardiomyopathy, or epsilon wave with localized bundle branch block, or some Brugada pattern, definitely you should alert the individual. You have to take the family history of any syncope, family history of any VTs, and any history of VTs. Then you have to go for ICD implantation to prevent your sudden cardiac death. Right? Any doubts? Simple thing. So just they asked about Brugada. I just want to mention two more ECGs which can be asked in the further exams. Right? Any doubts? Right. Let us go to the next question. Very important. I think people will answer this thing very easy question, but they have some issues there in this question. That's why I kept this question. A patient with a heart failure, with reduced ejection fraction. We know heart failure has three classification: heart failure, preserved ejection fraction, reduced ejection fraction, and mildly reduced ejection fraction. Right? And persistently elevated serum creatinine and also hyperkalemia. Patient has a serum creatinine elevated and also hyperkalemia. It is evaluated for the guideline-based medical therapy. Which therapy improves survival in this patient? Right? So what the examiner is asking, the patient is a known case of heart failure with reduced ejection fraction. The patient has come to you. You are giving a therapy. Now the patient has a increased serum creatinine and also hyperkalemia. So what are the drugs that can improve survival in this patient? That's what he is asking. Right? What is the answer here? Anyone can say? I want some of you to answer this question. So which drug can improve the survival in the patients of heart failure with reduced ejection fraction? Right. Right, let us see. So we all know there are 4 pillars of heart failure. There is an entity called as 4 pillars of heart failure. Very, very important. Okay, so why they're called 4 pillars? Because all these drugs, they can increase the survival of heart failure patients, and all these 4 pillars are usually they inhibit the RAS system. Most of the drugs, not all, they inhibit RAS system. So what are those drugs? One is called as ACE inhibitor or ARB. Okay. Also now the recent thing is ARNI. We'll discuss about that thing. Okay. Other thing is your beta blockers. Other thing is your mineralocorticoid receptor antagonist, that is your aldactone, spironolactone, those things. And other thing is your SGLT2 inhibitors, that is your dapagliflozin, empagliflozin. These are the 4 drugs which can improve survival in a patient of heart failure with reduced ejection fraction. Okay, any patient of heart failure with reduced ejection fraction has come to you. Your always goal is to introduce these 4 drugs step by step so that patient can improve the survival. Right? But the thing is, exam is tricky. What is asking, the patient has elevated serum creatinine hyperkalemia. So which drug can be given to improve survival in this patient is asking. Okay, so let us see the patient with a sacubital valsartan. Can you give for the patient who is having elevated serum creatinine hyperkalemia? No, because ACE inhibitors, ARBs, they cause hyperkalemia. You cannot give this drug. Right? Similarly, spironolactone is a potassium sparing therapy. Again, it causes hyperkalemia. Again, you cannot give this drug. And digoxin is no longer used nowadays. Before they used to use it, it's a potent inotropic action, but no longer they use. The answer is isosorbate dinitrate plus hydralazine. So single important thing what I am saying is, before and all they used to say there are 4 pillars of heart failure. So these are the things which can improve the survival, that is ACE inhibitor, beta blocker, MRA and SGLT2. Along with this, nowadays there is a 5th drug, that is what is called as hydralazine and isosorbate dinitrate. Very, very important. Hydralazine and isosorbate dinitrate. This is one more drug which can increase the survival in patients of heart failure. Right? Clear? So remember 4 plus 1, 4 is all the drugs you know, but 5th drug is also there because it's isosorbate dinitrate and hydralazine. It's a vasodilator. It can decrease the afterload, it can decrease the preload, so it can increase survival in the patients of heart failure. Right? So that's what the question is about. So just seeing the question should not put an this ACE inhibitor or ARB or ARNI, because even that improves survival, but in this clinical scenario where there is elevated creatinine and hyperkalemia, you cannot use ACE inhibitors, you cannot use ARBs, you cannot use ARNI, you cannot use your potassium sparing diuretic. Okay, so that's why these 2 options are gone, but examiner has kept in the first option because everyone wants to put sacubitril plus valsartan. Right? Clear? So this is what we discussed here. So these are the 4 pillars of heart failure treatment: ACE inhibitors or ARB or ARNI, then beta blocker and mineralocorticoid receptor antagonist is spironolactone, and then your SGLT inhibitors like dapagliflozin and empagliflozin. Right? This is the American Heart Association guidelines picture. Clear? I think simple bit only, just a tricky bit. Don't go immediately jump into the options. This also, for this there is no need to study Harrison and all. You just need to follow the patients, because so many heart failure patients are coming. You are giving ACE inhibitor, beta blocker, MRA and also SGLT inhibitors. But if patient is developing hyperkalemia, you are stopping ACE inhibitors. If patient is developing some renal failure, you are stopping ACE inhibitors. The same thing the examiner has asked, whether you are following rounds or not. That's it. Right? So one important thing I want to discuss about this thing, even though the examiner didn't ask about this thing, I want to discuss about this thing because it's very, very important drug. So what is this sacubitril valsartan? So this valsartan is angiotensin receptor blocker. We know this thing, this angiotensin receptor blocker, valsartan, telmisartan, candesartan, losartan, all these things are angiotensin receptor blockers. What is a sacubitril? Sacubitril is neprilysin inhibitor. Neprilysin inhibitor. So together it is called as angiotensin receptor neprilysin inhibitor, or NEET. Very very important. Current trending drug, current life-saving drug. Every cardiologist, every physician, whenever they're saying, they're trying to put this drug onto the patient because it has improved survival in many patients. Right? So why they asked angiotensin receptor blocker? Why they're mixing neprilysin inhibitor? We have to know this thing. So let us discuss in a brief way. So why you are giving neprilysin inhibitor? Before knowing this thing, you have to know what is called as neprilysin. What is called as neprilysin? Normally neprilysin is present in the body. So what is it doing? It is doing three things. Okay. Number one, it is metabolizing your pro-BNP, brain natriuretic peptide. Okay. So whenever there is any heart failure, your chambers are enlarged. So because of your chambers enlarged, what is going to happen? The chambers will release natriuretic peptide. The name itself says natriuresis. It helps to promote excretion of urine and water, so it can decrease the preload on the heart. So there are good stress hormones released by the stress of the heart, right? So but this is one which is metabolizing BNP. This neprilysin is metabolizing the BNP. Okay. Apart from this neprilysin also metabolizes angiotensin 2. This also metabolizes angiotensin 2. Very important things. Okay. Apart from this neprilysin also metabolizes bradykinin. Okay. So these are three actions of neprilysin. So neprilysin metabolizes BNP, neprilysin metabolizes angiotensin 2, neprilysin metabolizes bradykinin. Okay. So now what we are doing is we are giving neprilysin inhibitor. We are giving neprilysin inhibitor. That is your sacubitril. Okay. If you neprilysin inhibition, what is going to happen? Number one, you cannot metabolize the BNP. So there is increased brain natriuretic peptide. Okay. If brain natriuretic increased, so more natriuresis will happen, more water will be gone into urine, more sodium will go into urine. So it's beneficial in the heart failure. Accepted? It's beneficial in heart failure. Okay. If you give neprilysin inhibitor, so you are not metabolizing the BNP. So BNP levels are elevated for more time. So you'll have more diuresis. So more decrease in preload. So more beneficial in the heart failure. Right? Similarly, this neprilysin inhibitor, if you give, it is not metabolizing angiotensin 2. Your angiotensin 2 is also elevated. Okay. If angiotensin 2 is elevated, again your RAS system is getting activated. So much of side effects are there. That is why you should always combine with angiotensin receptor blocker. Very important. So that's why you should not give it alone as a neprilysin. You should not give alone as sacubitril. You should always combine with the angiotensin receptor blocker like valsartan or candesartan. Okay. And third thing, because of giving sacubitril, it cannot metabolize bradykinin. So there is bradykinin also elevated. Okay. Your ACE is the one which is metabolizing the bradykinin. So if you give combine with ACE inhibitors, you'll have a problem. So that's why you should never combine with the ACE inhibitor. So that's why don't combine with ramipril, don't combine with enalapril and all. Always combine with the valsartan and all. Right? So these are simple things. These are the questions they're asking. So what is sacubitril valsartan? It's an RNA. It's a basic question. Right? What is sacubitril? It's a neprilysin inhibitor. That's the second question. What are the actions of neprilysin? This is a PG level, SS level question. So neprilysin has three actions. It metabolizes BNP. It metabolizes angiotensin 2. It metabolizes your bradykinin. Right? When you give neprilysin inhibitor sacubitril, what is going to happen? BNP is not metabolized. BNP is elevated. More natriuresis, more decrease in preload, more improvement in heart failure. Right? Similarly, if you give sacubitril, what is going to happen? Angiotensin 2 is not metabolized, so angiotensin 2 levels are elevated. So that's why always combine with angiotensin receptor blocker. Okay. And similarly, if you give sacubitril, bradykinin is not metabolized, bradykinin is elevated. So that's why you should never combine with the ACE inhibitors. Very very important. And that's why the strongest dictum which was asked in the previous NEET was, whenever a patient is taking ACE inhibitors, okay, if you want to shift to the ARNI, stop ACE inhibitors and wait for 36 hours for the ACE inhibitors to completely wash out of the body. Then you can put the patient on ARNI. You should not stop today and immediately you cannot put on ARNI. Because ACE inhibitors when they used, there is always increased bradykinin. If you give ARNI also, again the bradykinin will be elevated. So that's why you give ACE inhibitor when you want to stop ACE inhibitors. Wait for 36 hours. Then after entire ACE inhibitors getting washed out of the blood, then you can give ARNI. right? All these are very important things. All these things are 3 important questions. These are 3 important questions. These are also very, very important questions, right? And this 36 hours is a very, very important thing. 36 to 48 hours they say, but 36 hours is a gold standard. Clear? Any doubts? Right? Right. Right. So if there's not a way, go to the next question also. So this is what the question they're asking. So even though they ask about only just simple heart failure question, what is the treatment? So you should know what are the 4 pillars of the treatment. Apart from the 4 pillars, what is the other drug which can improve survival in heart failure? That's isosorbate dinitrous hydride is very important. And the important thing is valsartan sacubitril. You should know what are the actions of neprilysin. So what are the effects which you come by giving neprilysin inhibitor sacubitril? So that why it is combining with the ARB. So why it is not combining with the ACE inhibitor. When a patient is taking ACE inhibitor, if you want to put on early, how much time you have to wait? It's 36 hours. All these are single line questions before they used to ask. Now they're asking in a case-based scenario. Right? Topics are same. The way the questions they're asked is different. But you are practicing clinically very well, and all these questions are very easy for you people. Right? Right. Right. Let us come to one more question they're asking. So by seeing the question itself, we say very big question, but it's nothing. It's there. Let's cut down the question. Right? A 52-year-old man with past history of treatment for classic Hodgkin lymphoma. The patient has a classic Hodgkin lymphoma. The patient is taking treatment for that. Okay. Now presents a progressive dyspnea and edema. So the patient has a progressive dyspnea and edema. It indicates your symptoms of heart failure. Accepted. The patient has dyspnea and patient has edema. Maybe symptoms of heart failure. And ECG echo shows bilateral atrial enlargement, but preserved LV systolic function. Very important. And features of right heart failure. JVP shows deep wide descent. What is the most appropriate diagnostic interpretation guiding further care? Right. So what patient is asking? The patient who had Hodgkin lymphoma. He took some treatment. We don't know what treatment it is. Maybe some chemotherapy or radiotherapy. Anything can happen. Right. After this, the patient developed symptoms of heart failure. So there itself we will crack the question, because after some chemotherapy or radiotherapy, so what is the disease will happen? Mainly it is cardiomyopathy. We'll discuss that thing. So patient has symptoms of heart failure. When they do echograph, they have some bilateral atrial enlargement, but LV function is normal. Right? And JVP there is deep wide descent. That's it. Simple. So this was the question they asked. We can write easily. So what are the things we'll see? Let us see. So after taking chemotherapy, radiotherapy, hypertrophic cardiomyopathy, right? It won't come after chemotherapy, radiotherapy. It's a genetic autosomal dominant disorder. It will come from the young age only. It is not seen after chemotherapy, radiotherapy, right? And dilated cardiomyopathy, in dilated the patient will have decreased ejection fraction, but here patient has normal systolic function. So this is also ruled out. And arrhythmogenic right ventricular cardiomyopathy, again this is also, it's a genetic disorder which happens in young age only, and it's not related in chemotherapy. So this is also ruled out. And the only thing left is restrictive cardiomyopathy, and we all know restrictive cardiomyopathy develops mainly because of some chemotherapeutic agents or some radiotherapy to the mediastinum. So which is seen because of Hodgkin lymphoma. So that's what the simple question they asked. So no need to discuss all these things. You can see the options and you can decide the answer, right? But before this thing, once they asked about JVP with deep wide descent and cardiomyopathy, we'll discuss few points about those things, right? So this is the JVP pattern we know already. I think since childhood you are studying all these things. So JVP is A wave, X descent, V and Y wave. A wave indicates your atrial contraction. We know already. Okay, and V indicates your venous return. And Y indicates your ventricular filling. Okay, suddenly blood from atria goes into the ventricle, so therefore there is a Y descent is there. The pressures in the atria fall down, there is a Y descent. We already know this. Now let us see what is the difference in tamponade and constrictive pericarditis. So what is tamponade here? Tamponade means completely the pericardium is filled with some fluid, or pericardium became fibrous, and pericardium is compressed in the ventricle. So ventricle is unable to dilate at all. It is unable to expand at all. Right? That is what is called cardiac tamponade. So completely here the pericardium is completely compressed in the ventricle. Now ventricle is unable to expand only. So then what is going to happen when ventricle is unable to expand? So whatever the blood that has to come from the atria, it is not coming. It's very slowly it is coming. Okay, very slowly it's coming, and there is no Y wave. Y wave is actually abrupt ending of the Y wave, ending of the Y descent. because whatever the blood that is there in the atria, it has to go to the ventricle, but ventricle is unable to expand, so the blood that is going from the atria is not going, it just slowly goes and it stays there only. So atrial pressures will be remain elevated, so the YY will be same, stagnant only. That is what's called abrupt ending of Y descent. This is same case of cardiac tamponade, right? But what is going to happen in constrictive pericarditis here? Here some pressure is there from the pericardium on the ventricle, but it is not completely blocking the ventricle. So ventricle is slowly it is expanding. So what is going to happen from the atria? It's coming, blood is coming from the ventricle. So ventricle is slowly expanding. So blood also slowly coming. So the Y descent will be prolonged. It's coming to, see, it's just normal Y descent. Here it's a prolonged Y descent. Prolonged Y descent. Simple. Okay, that is in case of constrictive pericarditis or restrictive cardiomyopathy. Anywhere you can see. Okay, so simple thing. So J waves, A wave, C wave, X wave, V and Y wave. So all these things you know already before they ask, but Y wave they definitely ask. So Y wave indicates your atrial filling into the ventricle. Anything that stops atrial filling into ventricle, Y wave abnormality can happen. In cardiac tamponade, there is complete pressure on the ventricle. Ventricle is unable to expand. So there is no blood coming from atria to ventricle. So all the blood is there in the atria only. Atrial pressure is not coming down. So there's completely Y wave is it's a straight line only. It's an abrupt ending of the Y line, Y descent. But in the case of constrictive pericarditis, it is slowly coming. So atrial pressure slowly dropping down. It will take a deep Y descent. This is called deep Y descent or prolonged Y descent. That is in constrictive pericarditis or restrictive cardiomyopathy. That's what they asked here. The patient has a deep Y descent. Okay. If they say the patient has a abrupt Y descent, then you can say it is a cardiac tamponade. Very important. Simple thing. Right. So let us discuss 2-3 points regarding cardiomyopathy. Very important here. When you say cardiomyopathy, you know 3 cardiomyopathies especially. One is dilated cardiomyopathy, restrictive cardiomyopathy, and hypertrophic cardiomyopathy. Okay, so dilated always important. Infection is the main common cause. Infection like viral, Coxsackie, or any parasite also, toxoplasma, all these things. Apart from that, very important is alcohol. Apart from that, very important is hypothyroidism. Apart from that is hypocalcemia. Very important causes of dilated cardiomyopathy. So now what is going to happen? The name is dilated cardiomyopathy. All the chambers are dilated. All chambers are dilated. Okay. If all chambers are dilated, what is going to happen? Understand here. If all chambers are dilated, the chambers are thinned out. The ventricular muscle is thinned out, right? The chambers are becoming dilated means the ventricular muscle is thinned out. If it is thinned out, the force of contraction is very less, right? The force of contraction is very less. So that's why it's a systolic heart failure. They produce systolic heart failure. Accepted here. So how will you know systolic heart failure? Systolic heart failure is reduced ejection fraction. With reduced ejection fraction. 1 minute, sorry. Right. With reduced, right? So DCMP mostly seen in infections or alcohol or hypothyroidism or hypocalcemia. Examiner definitely give this history as infection is there or some alcoholic is there, patient hypothyroidism or patient hypocalcemia is there. But when you do echocardiography, all the chambers are dilated. Because chambers are dilated, so what is going to happen? The chambers, the ventricular muscle become thinned out, so it is unable to contract strongly. So it is systolic heart failure. There is reduced ejection fraction. Okay. Along with this thing, the ventricular chambers are dilated. What is going to happen? The valves also problem will come. The patient have MR or a TR. Very important. Very important thing. Okay. Right. Right. Let us go for the restrictive cardiomyopathy. So what is going to restrictive cardiomyopathy here? So something is restricting. So ventricle has to expand, but it is restricting. Okay. So that means here what is going to happen? It's mainly because of some chemotherapy or some radiotherapy or some fibrosis and all. Okay. So history will be given like the patient is taking some chemotherapy or radiotherapy or some amyloidosis, some infiltrated disorder like amyloidosis, sarcoidosis. So because of this thing, something is infiltrated in the myocardium, so myocardium is unable to expand. Okay, because myocardium is unable to expand, what is going to happen here? So blood is not coming into ventricle. It's a diastolic heart failure. It's a diastolic heart failure. Very important thing. Okay, so here EF is always normal, systolic is normal, but diastolic ventricle is unable to get the blood because ventricle is unable to expand, so more amount of blood is not coming into ventricle, so it's a diastolic heart failure, right? And hypertrophic cardiomyopathy, very simple, it is, you already know, it's always young adults, it's always young athletes. Okay, so definitely they have septal hypertrophy, asymmetric septal hypertrophy. Okay, ECG will have deep T inversions, and echo will have asymmetric septal hypertrophy. So usually they give history of any young athlete, suddenly there is sudden cardiac death and all. This is the history they will give. Okay, so very important thing. So now let us see, come back to the question, what is doing they asking. So 52-year-old man, past history of classical Hodgkin lymphoma, patient has a malignant history, that means patient is taking some chemotherapy, radiotherapy, now progressive distal edema, here symptoms of heart failure, echo shows bilateral atrial enlargement, only atrial enlargement but not ventricle, preserved LV systolic function, LV is very nice, that means there is no dilation of chambers, there is no systolic failure, and features of right heart JVP is there, and JVP has a deep by descent. Deep by descent indicates slowly there is spilling of blood from the atria into ventricle, so there is some restriction is there, so it's a restrictive cardiomyopathy. Clear? Very simple question, just keep it kept in 4-5 lines, they're making you confuse in the exam, but really if you very peacefully if you read the question, it's very easy. Right? Okay, let's go to the next question. Right. Right. These are simple question they asked in the last year exam. So let us see what is this question. A 68-year-old diabetic patient who has evidence of renal dysfunction. He is a diabetic. He has a diabetic renal dysfunction. He has a past history of TIA, transient ischemic attack. He is now planned for coronary angiography. They want to do coronary angiography. Which of the following should not be given before the procedure? This is what they are asking. Okay. Any guess you can do here? Right. So what I want to say is, here the patient, exam is asking, the patient want to do coronary angiography. The patient want to do coronary angiography. Okay. So before doing coronary angiography, the patient also has a renal dysfunction. The patient also has renal dysfunction. So what should not be given is asking. So let me explain first. Before doing coronary angiography, what all things you have to give to the patient, right? Because already patient has renal dysfunction, and coronary angiography, there is a contrast-induced nephrotoxicity possibility is there. You will definitely give IV fluids. Okay, you will definitely give IV fluids. Then you do coronary angiography, right? And second thing is, because you are doing coronary angiography, so you are disturbing the plaque and all. So definitely give antiplatelets plus anticoagulants. Both things you have to do, right? So this is the reason why in the case of STEMI or in the case of NSTEMI, before doing angiography, you give loading dose of antiplatelets and also heparin also. Why you are giving this thing? Because by doing angiography, you are disturbing the plaque. So these platelets can cause aggregation some other place, and they cause this plaque progression also. So that's why you are giving antiplatelets and anticoagulants in this patient before doing coronary angiography, right? So before doing coronary angiography, in STEMI protocol also you are giving heparin, then you are going for the angiography. Similarly, you are giving loading dose of aspirin, clopidogrel, that's antiplatelets, then you are going for the angiography. This the reason is, you want the plaque should not progress, and you want the platelets to be inhibited, so to prevent the further progression of the plaque. So that's why giving this thing. Now what is asking is, which should not be given is asking. Yes, 0.9% saline is correct. IV soda bicarbonate, okay, not that much, we'll see. Tablet aspirin antiplatelets, yes, you have to give, and tablet prasugrel, both antiplatelets are there. So now what should be given, what should not be given? Okay, so before this thing, you have to know, this is hematology topic. You have to know what are the antiplatelets. Okay, so what are the antiplatelets, you know? If you see the antiplatelets, there are definitely 3 classes are there. One is COX inhibitor. That you know already, it is a aspirin, the most commonly used, that is aspirin. Okay, in low dose, high dose, it inhibits thromboxane U2, so it prevents platelet aggregation. And other is what is called as P2Y12 inhibitors, that is ADP receptor inhibitors. Okay, in antiplatelets, one more drugs called P2Y12 inhibitors, ADP receptor inhibitors. If you see this thing, in these 2 things are very important. In these 2 things are there. One is called as irreversible and reversible. Okay, Irreversible are your clopidogrel and prasugrel. Why I'm giving this flowchart is this was a question they asked. What are the irreversible P2 vital inhibitors? That's a question they asked. And reversible are your cangrelor, ticagrelor. Okay, and other drugs are your GP2B 3A inhibitors. So what are those drugs? They are your abciximab, ectifibatide, and tirofiban. So the three drugs are there. Very, very important. So why they asked is what is the GP2B3 inhibitor that we used in case of coronary syndrome? This is tirofiban we are using before because there are any injectables, infusions and all before doing coronary angiography or after doing coronary angiography we are giving as infusion tirofiban also. Okay, but in the case of this P2 vital, clopidogrel, these all things are giving as a loading dose and COX inhibitor aspirin. One important point here is this prasugrel, very, very important. It should not be given contraindicated in individuals with stroke. Individuals with stroke or TIA. Why? Because it has more chance of hemorrhage, conversion because it's an irreversible P2 vital inhibitor. So it has more chance of hemorrhage conversion. So that's why if patient has a stroke or a TIA, you are never giving prasugrel. That's what the question they asked. So simply we say this thing, yes, a diabetic patient, he has renal dysfunction, he wanted to do coronary angiography, yes, you will give fluids because to prevent your contrast-induced nephropathy. And soda bicarbonate, it's not, some people will try to give, but there's no much studies. Aspirin, yes, you will give antiplatelets before doing coronary angiography, but prasugrel, you should not give here because the patient had history of TIA. If there is history of TIA, prasugrel is strictly contraindicated because it's irreversible P2 vital inhibitor which can cause hemorrhagic transformation of the infarcts. So that's why if a patient has history of TIA, if patient has history of stroke, you should never give prasugrel. Simple point, they just framed a question. Right? Simple? Right? That's why this is very important. So this was the question they asked before also. What are the irreversible P2 vital inhibitors? Clopidogrel, prasugrel. Apart from that, prasugrel you are never using because it is in a history of any stroke or TIA, definitely you won't use prasugrel. Very important. Right? Clear? Right. Just a minute. Right, very, very important. This is very, very important question. I think every year this topic will come. Let us deal this topic very nice. Now, patient presents with chronic diarrhea. Patient has diarrhea, migratory arthritis, and diffuse skin hyperpigmentation. So, what is the diagnosis they're asking? Anyone can say diagnosis. A small intestine biopsy is performed. Which of the following histopathology findings is more characteristic of the underlying disease? Right. So, a bit difficult question. Before doing this thing, I just want to discuss about malabsorption. They're discussing about malabsorption. The patient has a chronic diarrhea. That is a hint. Chronic diarrhea, weight loss. The patient has a malabsorption. Right. When you see the malabsorption, okay, in the malabsorption, anything can happen because of some absorptive problems or because of some mucosal problems. So, this is mucosal problems. For example, intestinal mucosal problems are there. You need to understand some 3-4 diseases. Very, very important. Right. What are the diseases? See. So, we were discussing about the malabsorption problems. So, malabsorption which occurs because of the intestinal mucosal problems. So, there are some certain diseases are there, very, very important. Right? The first is your celiac disease. Okay. Other is your Whipple's disease. Very, very, very important topic I am discussing now. Whipple's disease. Okay. And other is your what is called as tropical screw. Other is tropical screw. Okay. And other is what is called as your subacute intestinal, small intestinal bacterial overgrowth SIBO, and other is last and final A beta lipoproteinemia. Very, very, very important. Please remember this chart. It comes throughout your life. Whenever there is malabsorption because of mucosal problems, there are especially 5 diseases are there. One is celiac disease, Whipple disease, tropical screw, SIBO, and A beta lipoproteinemia. So they're asking your patient is having some chronic diarrhea, it's a malabsorptive problem, and small intestine biopsy is performed. So which of the following findings is assessment? They are discussing about malabsorptive mucosal problems, right? So let us discuss one by one. So celiac disease, very easy here. Patient has celiac disease means the patient has a gluten sensitive enteropathy. What is this one? Gluten sensitive enteropathy. That means whenever the patient is taking some gluten like rice, jowar, wheats and all, whenever it's taking the thing, it's very sensitive. Antibodies are developed against this thing and they're damaging your intestinal mucosal cells. That's called gluten sensitive enteropathy. Especially it affects duodenum. Okay, sometimes it affects only duodenum. If patient affects only duodenum, usually the patient will have iron deficiency anemia, right? But along with duodenum, if patient has a jejunum and ileum are also involved, then the patient will have malabsorption features like diarrhea, weight loss, and steatorrhea. The diarrhea, weight loss, and steatorrhea. Simple, right? So gluten sensitive enteropathy. Whenever the patient is taking some gluten-containing diet, antibodies are formed against this gluten. It also acts in intestinal mucosal cells and causing damage to intestinal mucosa. If it affects only duodenum, the patient will present as iron deficiency anemia. If it affects duodenum plus jejunum plus ileum, definitely the patient has a chronic diarrhea, weight loss, steatorrhea. All these things will happen. Right? So how will you diagnose? You can diagnose by seeing some antibodies. What are those antibodies? There is a tissue transglutaminase IgG antibodies or anti-endomycin antibodies, and anti-gliadin antibodies. Very, very important. Very, very, very important. Okay. All these things they asked already. Celiac disease is a favorite question for the examiners. So what is the antibody that is screen? Tissue transglutaminase IgG. Very important. Okay, and how will you diagnose? Always you do the biopsy. In the biopsy, very important is you have crypt hyperplasia. And villus atrophy. Very, very important. Villus atrophy. Crypt hyperplasia and villus atrophy. Very important, right? Okay, so simple. It's a gluten sensitive enteropathy, affects duodenum, producing as iron deficiency anemia. Duodenum, jejunum, ileum, entire small intestine produces chronic diarrhea, weight loss and all. Antibodies, tissue transglutaminase IgG plus anti-endomycin plus anti-gliadin antibodies. Anything can be positive. If you do the biopsy, you'll have crypt hyperplasia and villus atrophy in the small intestine. That's simple thing. So treatment is actually you have to remove the gluten from the diet. The patient will resolve from the symptoms. Then comes the Whipple disease. What is happening in Whipple disease? Let us see. In Whipple disease, the organism is called as Treponema whipplei. Right? So what is this organism doing? This organism is harboring in the intestinal cells and is causing damage to intestinal mucosal cells and is causing your malabsorption symptoms. Okay. One important thing is this is periodic acid shift positive. Okay. This is periodic acid shift positive. This organism is periodic acid shift stain positive. So that is why this organism is engulfed with the macrophages and they stay in the intestinal epithelial cells. Whenever you do the biopsy and you do this PAS positive, you will find out what is called as PAS positive macrophages. Very, very important. PAS positive macrophages. Very important. Right? But very, very important thing I want to mention here, in Treponema whipplei disease, what is going to happen here is the patient will have chronic arthritis. Very important. Chronic arthritis. The patient will have chronic arthritis, and after some 5 years only, then patient develop malabsorption symptoms. So usually you will treat this arthritis as serum to arthritis in your OPD and all, but later and all you will develop malabsorption symptoms. Patient become weight loss, patient develop diarrhea and all. When you do the intestinal biopsy and you see this PAS positive macrophages, then only you will diagnose Treponema whipplei. That's called Whipple disease. Okay, very, very important thing. So this patients will have, apart from malabsorption, you will have arthralgia features also. When you do the intestinal biopsy, you will have PAS positive macrophages. Okay, then let us come to tropical sprue. Very important. Tropical sprue, nothing else is there. This tropical sprue here because of some multiple organisms, because of multiple bacteria. Okay, they just grow in the lamina propria. So you have inflammatory infiltrate in the lamina propria, inflammatory cells in the lamina propria. That's it. Nothing much is important. So this is also causing some diarrhea, weight loss and all. When you give rifaximin, all these antibiotics, all these microbes can be cleared. Then comes the SIBO. Very important here, SIBO. So what is the SIBO? Small intestinal bacterial overgrowth. In the small intestine, so many bacteria are overgrown. Because of this bacteria overgrown, what they are doing, they cause malabsorption because they are all damaging the mucosa and they are also consuming whatever the food you are taking. They cause bacterial overgrowth. Because this malabsorption also, small intestine only helps in absorption B12 and folate. They have folate plus B12 deficiency. Sorry, they have wait 1 minute. Right, they have B12 deficiency. Right, they have B12 deficiency. But important thing is in the SIBO, what is going to happen? The bacteria are there. The bacteria are producing more amount of folate, so folate is elevated. Very important. Okay, folate is elevated. Very important. right? And this tropical sprue has one important point here. It's multiple bacteria. All these bacteria causing damage to mucosa. So along with the malabsorption, they'll have B12 plus folic acid deficiency is there. That's the only difference here, right? Clear? But here in SIBO, the bacteria is there. Okay, B12 deficiency is there, but the bacteria produces more and more amount of folate. So folate levels are elevated. Very important, right? And next comes very important thing is A beta lipoproteinemia. What is this A beta lipoproteinemia? A beta lipoproteinemia. Here the problem is okay. Here the problem is the chylomicrons are not transported. Chylomicrons are not transported across the intestine. Okay, so you know chylomicrons, they're formed in the intestine and they have to transfer your triglyceride cholesterol into the blood circulation. So in A beta 11, chylomicrons are not being transported from the intestine to blood circulation. So your lipids and all, they are not going to blood circulation. So lipids, they have steatorrhea, malabsorption, diarrhea and all. When you do the biopsy, you will have what is called as lipid-laden macrophages. Very important, lipid-laden macrophages. This is the diagnosis. Simple. So this is a very important thing, malabsorption mucosal problems. So let me explain again to you people. So what is this thing, malabsorption actually? So malabsorption can happen because of anything, but if intestinal mucosa problem is, that's called mucosal problems. So 5 diseases very important. One is celiac disease, Whipple disease, tropical sprue, SIBO and A beta lipoproteinemia. Right? Celiac disease, it's a gluten sensitive enteropathy. Whenever the patient takes a gluten, then only antibodies are formed and the damaging intestinal mucosal cells. If duodenum is involved, they produce iron deficiency anemia. If duodenum, jejunum, ileum, entire small intestine involved, they have malabsorption, chronic diarrhea and weight loss. Right? So what are the antibodies? So tissue transglutinous IgG antibodies, anti-endomycin antibodies, anti-gliadin antibodies. So how will you diagnose? When you do the biopsy from the duodenum or jejunum, you will see crypt hyperplasia and villus atrophy, very characteristic. Right? But in the case of Whipple disease, the organism is Trichoderma whipplei. It stays in the intestinal epithelial cell and causing damage to intestinal epithelial cell. One characteristic feature is they have PAS staining, periodic acid shift positive. So that's why when you do the biopsy, you will have PAS staining macrophages. Very important. That's a diagnostic. Right? In history, they will give chronic arthritis. After 5 years, it develops some malabsorptive features. Right? And tropical sprue, multiple organisms. So that's why they have complete malabsorption plus B12 and folic acid deficiency. But in SIBO, yes, small intestinal bacterial overgrowth, this bacteria causing malabsorption along with this B12 deficiency, but bacteria producing more amount of folate, so folate is very much elevated. And last is A beta lipoproteinemia. Here the problem is defective transport of chylomicrons. So chylomicrons are not being transported, so there is no digestion of the fats, so therefore there is malabsorption, and in biopsy you will have macrophages with lipid-laden macrophages. Right? Very important. So this important thing you have to see. Whenever they say crypt hyperplasia, villus atrophy, you will diagnose celiac disease. Whenever there is chronic arthritis and malabsorption and periodic acid positive, you will diagnose as Whipple's disease. Whenever they say all complete malabsorption with butyl folic acid deficient, you will say tropical sprue. Along with this, when folate is elevated, you will say SIBO. And when lipid-laden macro, you will say it as a beta lipoproteinemia. So please remember this chart. Please keep this chart. With this chart, you are going to answer some 30 questions I am saying. Every year, one of the diseases will come in NEET tests. Okay, so let us see this question now. So what is the question they are asking? A patient has a chronic diarrhea and migratory arthritis. Again, same. I told you, arthritis plus diarrhea. Simple. So definitely the question is, the answer is arthritis plus diarrhea. Arthritis mala, it's a Whipple disease. Simple. A small biopsy confirmed which are the following histopathological finding is characteristic of underlying disease. We already discussed the Trichoderma whipplei is a PAS positive organism. So you will see periodic acid shift positive macrophages. Right? So what is this one? Lymphocytic infiltrative lamina properties seen in tropical sprue or disease is Whipple disease. Villus atrophy is seen in celiac disease. Okay, and granulomas is seen in inflammatory bowel disease. Right? And our diagnosis periodic acid positive macro because it's a Whipple disease. Simple. Any doubts? Examiner's favorite question because we usually neglect these questions in theory questions also, and less patients will see in the exam in OPD also. So that's why they'll ask this type of questions. Right? Whenever they ask arthritis and malabsorption, come to Whipple disease, PAS positive. Whenever they ask some malabsorption, crypt hyperplasia, villus atrophy, celiac disease. Whenever they ask some malabsorption, butyl folic acid deficiency, tropical sprue. Folate elevated, SIBO. Lipid-laden macrophages, you go for your A beta lipoproteinemia. Simple. It's very simple. Okay, please remember this chart forever. Right? Okay. Right. Let us go to the next question. Right. So this is again from gastro. What is the question they're asking? Following achievement of clinical and biochemical remission in a patient with autoimmune hepatitis, which of the following is appropriate long-term management strategy? So what exam is asking? Exam is asking about autoimmune hepatitis. Patient has autoimmune hepatitis. Which of the following is appropriate long-term management is asking? Okay. If you don't study autoimmune hepatitis, you don't know what is autoimmune hepatitis. How to crack this question? Let us see. Okay. So you know already autoimmune hepatitis because of auto-inflammatory mechanism. Definitely you will give steroids like SLE, autoimmune mechanism, Sjogren's syndrome, autoimmune mechanism. Okay, you are giving some steroids only. Let us know because you are doing PG practice, you are doing clinical residency for 3 years. You know autoimmune mechanism will give steroids only. So now what is asking? What is the following after long-term management strategy? Let us see now. So continue combine through azothioprine corticosteroid indefinitely. Any disease do you give corticosteroids indefinitely? You will never give corticosteroids indefinitely because they are causing bone osteoporosis. Not so that option is wrong. And use corticosteroids alone as maintenance therapy. Maintenance also cannot give corticosteroids because long-term use of corticosteroids can cause osteoporosis, right? And stop treatment because patient achieved remission. You cannot stop treatment because it's autoimmune process. And only option is remission with azothioprine monotherapy. Simple thing. Even though you don't know autoimmune hepatitis, don't get feared of the questions. Just see the options. Use your clinical sense. You will practice so much in your PG periods. You just see the questions. We can answer the answer. Okay. So this thing. Let's discuss about autoimmune hepatitis. Few points. Autoimmune hepatitis. Why? Because once exam asks this question means definitely he will ask about some complicated question next time. So you have to know about autoimmune hepatitis. We all know autoimmune hepatitis, autoantibodies against your liver producing hepatitis, and it leads to again cirrhosis. It leads to again your carcinogenic also. So what is the thing is main important thing what examiners are interested in is it is two types are there, type 1 and type 2. Type 1 and type 2, very important. Okay, when you say type 1, it is usually seen in the case of young women, very important. And type 2 usually seen in case of children, very very important. Okay, so in a pediatric age group, if you diagnose autoimmune hepatitis type 2, in the case of adult age group, it is young women, it is in the case of type 1, right? Okay, so what is going to happen here in autoimmune hepatitis? ANA is strongly positive. Apart from this, you will have what's called as anti-smooth muscle antibody positive, and apart from this, what's called as anti-liver kidney muscle positive. Very very important. What are the three antibodies that are positive in autoimmune hepatitis? ANA positive, asthma positive, anti-LKM positive. Apart from this, you will have soluble liver antigen positive. So 4 antibodies are there. Okay, but in the case of type 2, you won't see all these things. Usually you see what is called as anti-LKM1. Very very important. Anti-LKM1. All these things are not so much prevalent, but this antibody is very much prevalent in case of children. Right, simple. So what is the treatment? Treatment is always steroids. Is 0.5 to 1 mg per kg will start. Once patient achieves remission, what is achieves remission? LFT becomes normal. Transaminase is decreased. In biopsy also, if that hepatitis is decreased, then you can start to step to azothioprine. Azothioprine is 2 mg per kg. Okay. If not responding, then you can go for other drugs like cyclosporine, rituximab, all these things. But at least these things are important. Okay. Here one more important NEET SS question. One important is what is anti-LKM1, anti-liver kidney muscle 1? It's not related to autoimmune hepatitis. Simple thing I am saying, this anti-LKM1, anti-LKM liver kidney muscle antibodies, there are 3 types are there, very important. Type 1, type 2 and type 3. This was a question 2 years back they asked. Okay, this type 1 is seen in case of autoimmune hepatitis. Type 2 we discussed only. Type 2 is seen in case of drug induced liver injury, DILI, and type 3 is seen in case of chronic hepatitis B. That's it. This type 3 is the question previously asked. It's a normal simple question I am saying, not related to autoimmune hepatitis. Right? So autoimmune hepatitis, type 1 and type 2. Type 1 is in young females, type 2 is in children. What are the antibodies? ANA, asthma, anti-LKM and also soluble liver antigen. Usually give steroids. If not responding, go for your azothioprine, but maintenance is always the azothioprine. Stop steroids as soon as possible. In type 2, it's still children. The most common antibody in type 2 is anti-LKM1. Okay, when you see LKM, there are 3 antibodies, 1, 2 and 3. 1 you see in case of autoimmune hepatitis, 2 you see in case of DILI, and 3 you see in case of your chronic hepatitis B. Right, clear? Simple. Let us see the question. Following achievement of clinical remission, biochemical remission, patient which of the following is appropriate long term? Long term always management with the azothioprine, never steroids. So maintain with azothioprine monotherapy. That is about 2 mg per kg. Right? Clear? Right. So let us go to this question, very important thing. This is from endocrinology, I took this question. Right. So this one endocrine question I'm taking this thing. So patient with intracranial hemorrhage on mannitol. Yes, we know any intracranial hemorrhage you're putting some osmotic diuretic, that is mannitol. Now patient develops polyuria 4.5 liters per day, serum osmolality of 280, urine osmolality is 110, that is low, urine sodium is 10, that is again low. What is the most likely diagnosis? Okay, you don't know anything now. Now you don't know what is this thing, what's the question, and how to approach this question. Let us see. Osmotic diuresis. If osmotic diuresis means when you give mannitol, it is causing diuresis. If osmotic diuresis is happening, what is going to happen here? Urine osmolality should be high, but urine osmolality is low here, so it is not the thing. Okay, and then comes cerebral salt wasting. That means cerebral salt wasting. Because of cerebral problem, salt is wasted, salt is losing the urine, then urine sodium should be high, but urine sodium is low here, so this is also gone. And these two things are there: nephrogenic and central diabetes insipidus. Okay, the patient has intracranial hemorrhage, that means problem in the brain, so it is central diabetes, it's not a nephrogenic. Simple. So there's no need to know about diabetes insipidus. Just based on the questions options only, you can rule out the options and you come to the answer. Right? So simple. Let us see again. Patient has intracranial hemorrhage. The patient is giving mannitol. He develops polyuria. Now patient has serum osmolality 280, which is normal. Urine osmolality is low. Urine sodium is low. What is the most likely diagnosis? It is not osmotic diuresis, because if there is osmotic diuresis, this mannitol is there in the urine. Urine osmolality should be high, but it is low, so it is not ruled out. And cerebral salt wasting means through the brain your sodium is getting wasted and is going into urine. That means urine sodium should be high. That is also not the possible thing. And nephrogenic, it's not about nephrogenic intracranial central diabetes insipidus. Okay, so let us discuss about a few points regarding diabetes insipidus. Very important here. Okay, so what is diabetes insipidus? Okay, so decreased ADH leads to increased production of urine, increased production of diluted urine. So how much urine you will calculate as the diabetes insipidus? That is about 50 ml per kg. Very important. That means for 60 kgs man, it's always 3 liters of urine. If patient is producing 3 liters of dilute urine, you can diagnose, you can label him as a diabetes insipidus. Okay. Now in the diabetes insipidus, what are the two different things are there? One is your primary nephrogenic and other is central. One is central diabetes insipidus, another is your nephrogenic diabetes insipidus. Okay, so you know what is ADH? ADH is anti-diuretic hormone, which is produced from the posterior part of the pituitary gland. Right? Any problem in the brain, so there is no production of ADH. That is what is called as central. That is, there is decreased ADH production. Decreased ADH production. But nephrogenic, what is going to happen? This ADH is going to act on the kidney collecting duct through aquaporin 2 channels and helps in absorption of water. So ADH is normal, but the problem is in the kidney. Problem is in the kidney problem. So here ADH levels are very high. ADH levels are very high. Simple. Right? So what is going to happen in this case of diabetes insipidus? In diabetes central, there is no ADH. Because there is no ADH, so there is no free water reabsorption. Okay, so therefore all the water is going into the urine, so urine osmolality will be low. Okay, so because all the water is going into the urine, so you have increased serum osmolality. Simple. Similar nephrogenic also, even though ADH is there, it's unable to act on the kidneys, so therefore urine will be going free urine, so urine osmolality will be low. Clear? So how will you diagnose here? In the case of central diabetes insipidus, definitely you have to diagnose through MRI brain. You have to diagnose through MRI brain. In MRI brain, you have to see the T1 image. Very important. T1 image we use in very few conditions. In the T1 image, you should be able to see the bright spot. This bright spot indicates a posterior pituitary. If this bright spot is absent, you can suspect diabetes insipidus. Bright spot is absent in case of T1 imaging, then you can suspect your diabetes insipidus. Right? In nephrogenic, MRI brain is normal because there is no problem in the brain. MRI brain is normal. So how you can see? You can see serum ADH levels are very highly elevated. Here serum ADH is very low. It is not produced. Okay, or ADH, the co-product is copeptin. Nowadays you are using copeptin. It's highly elevated. Simple. Right? Clear? So just simple thing. So what I want to say is the questions are very easy and clinical oriented questions. So patient has intracranial hemorrhage, on mannitol develops some polyuria. Don't think it as some osmotic diuresis. If it is osmotic diuresis, urine osmolality should be high. If it is cerebral salt wasting syndrome, urine sodium should be high. So both are not there. So it's a diabetes insipidus. Especially if the problem is in the brain, it's central diabetes insipidus. So that's why we discussed about central diabetes insipidus. Because ADH is low. If ADH is low, it is not absorbing. So more amount of free water is going in urine. So urine osmolality is low and serum osmolality is high. Right? How will you diagnose? MRI in T1 image, you will see the bright spot. If the bright spot is not there, you can diagnose it as a central diabetes insipidus. And ADH levels are very, very low. This is the important question they can ask in the future exams. But in case of nephrogenic thing, MRI is normal, but ADH is elevated or copeptin is highly elevated. Right? Simple. Simple. Right? Let us go to the next question. Very, very important things. Says a big question is given. Okay, any doubts in this question? This is a question taken from the nephrology last year paper. We can see this thing. I think 1 or 2 questions are there. So very important thing. It's a question taken from your nephrology paper last year. NEET SS nephrology. You don't think it as a very big question. Just read along with me. It's easy for you to handle this question. A 26-year-old woman with history of recurrent UTIs develops acute pyelonephritis. She developed some pyelonephritis. Her urine culture grows E. coli, which is sensitive to gentamicin. After loading dose followed to maintenance therapy for 10 days. He have given gentamicin for 10 days. Now patient developed hypokalemia, hypocalcemia, hypomagnesemia. What does it indicate? Patient has developed hypokalemia, patient has hypocalcemia, hypomagnesemia. That means the problem is a tubule, renal tubule. Okay, because your calcium is absorbed from the tubule, your sodium is absorbed from the tubule, your potassium is absorbed from the tubule, your magnesium getting absorbed from the tubule. So it's a tubular disorder. The exam discussing about tubular disorder. And he has a hypercalciuria. Urinary calcium is very high. Normal blood pressure. So which are the following symptoms most likely induced by gentamicin? Simple. So patient examiner discussing about tubular disorders. So before going into this answer, so let me explain tubular disorders in a very small, easy table for you. Okay. So what are the renal tubular disorders? Renal tubular disorders. Right? If you see renal tubular disorders, especially for your level, we have to remember about 4 disorders. Okay, 4 disorders. Number 1, which is Bartter syndrome. Okay, and other is what is called as Gentleman syndrome, and another is what is called as Liddle syndrome, and another Gordon syndrome. Very important. Please remember in this sequence, it is easy for you to do. Bartter syndrome, Gentleman syndrome, Liddle syndrome, and Gordon syndrome. Right? Right, let us see. So Bartter and Gentleman, they both are autosomal recessive. Autosomal recessive. Okay. Liddle and Gordon both are autosomal dominant. Autosomal dominant. Okay. And Bartter syndrome is a loss of function mutation. That means some function is lost. Loss of function mutation. Even Gordon also loss of function mutation. Okay. And this Liddle and Gordon are gain of function mutation. Is also gain of function mutation. That means some pump is acting very active, that is gain of function mutation. Loss of some pump is going not working, that's loss of function mutation. Okay, so what is the pump that is involved here? In Bartter syndrome, it is a sodium potassium 2 chloride pump. So where is the present resulting in thick ascending loop of Henle, very important. Okay, and Gentleman, there is loss of function mutation in sodium chloride pump, which is seen in case of DCT. Okay, and Liddle is a gain of function mutation of ENaC channels, which is seen in collecting duct. Okay, and Gordon is also gain of function of sodium chloride, it's also DCT. So Gordon is exactly opposite of Gentleman. Right here, this is a basic difference they're asking. Bartter, Gentleman, Liddle, and Gordon. Bartter and Gentleman are autosomal recessive. Liddle and Gordon are autosomal dominant. Bartter is a loss of function mutation in the sodium potassium 2 chloride, which is seen in thick ascending loop of Henle. And Gentleman is a loss of function mutation in sodium chloride, which is seen in DCT. Liddle, it's a gain of function mutation in ENaC channels, and Gordon, it's a gain of function mutation in sodium chloride. Don't worry, we'll discuss all these things again here, right? So let us see here thick ascending limb. This is a sodium potassium 2 chloride pump. Okay, so what is this pump doing? This pump is simply it's absorbing the sodium. Okay, sodium is absorbed. Okay, it's absorbing the potassium. Right, this is the lumen. This is the lumen here. You can understand this is the lumen. It's absorbed to the cell and going to the blood. Sodium is absorbed. Yes. Potassium is absorbed. Yes. Right. Very, very important. Please understand here. One important NEET SS question is there. Now, if you see the potassium, even though it get absorbed, now potassium is going again outside into the lumen. because it is going outside, it generates some electrical potential. By using that electrical potential, now the calcium and magnesium are coming into the interstitium. So it helps in absorption of calcium. Okay, it helps in absorption of calcium. It helps in absorption of magnesium. Accepted here, accepted. So sodium is absorbed, potassium is absorbed, but this potassium again leaking through the leaky channels because of that some electrical potential is created. With that potential, your calcium and magnesium are absorbed into the interstitium. So sodium absorbed, potassium absorbed, calcium absorbed, magnesium absorbed. Important question is this calcium and magnesium are absorbed through thick ascending limb through paracellular route. Very important question. Paracellular route. They're not coming through the any channels. They're just coming this one cell through the paracellularly they're coming. Important thing. Right? Now let us see if this pump is not there. If this pump is not there, what is going to happen? Okay, there is no sodium absorption. There is no sodium absorption. So you have some small hyponatremia accepted. Okay, no calcium absorption. So hypocalcemia accepted. No magnesium absorption. So hypomagnesemia accepted. Important thing, if calcium is not absorbed, what is going to happen? The calcium is going in the urine. So your urinary calcium is increased. Your urinary calcium is increased. Clear? Okay. And one more important thing is because if sodium is not absorbed here, this thick ascending limb is in the medulla. So your medullary osmotic gradient is affected. So there is no absorption of free water also. It's a potent diuretic agent. Potent diuresis. Diuresis will happen. Okay, clear? Everything clear? Right? Let me explain again here. Very simple things here. So usually sodium, potassium, 2-chloride, thick ascending limb group of Henle. It helps in absorption of sodium. It helps in potassium. It helps in absorption of calcium and magnesium. And this calcium magnesium is going through paracellular route. Right? When this pump is not there, then there is no sodium absorption, hyponatremia. There is no calcium, hypocalcemia. There is no magnesium, hypomagnesemia, and it's a potent diuresis agent. And because there is no calcium is getting absorbed, calcium is lost in the urine. So urinary calcium is very high. It's hypercalciuria. Get clear? Everything is clear. Let us come into the gentleman. Okay, so gentleman, it is a sodium chloride pump is gone here. So what is the sodium chloride pump is doing here? Again here, sodium absorption. Yes. Okay. Now here is the thing happens here. So what is the sodium absorption? Also calcium absorption. Calcium is also somewhat absorbed. Okay. Now this pump is for both calcium and magnesium. Both calcium and magnesium. So when our body needs calcium, calcium is absorbed. When our body needs magnesium, magnesium is absorbed. Yes, the pump is same for both calcium and magnesium because both are divalent cations. So same pump is there. Okay. Now let us see what is going to happen in gentleman syndrome. So in gentleman syndrome, there is no sodium chloride pump. Because there is no sodium chloride pump, no sodium is absorbed. So there is a hyponatremia. Now the thing happens. If there is no sodium is getting absorbed into the cell has to take some sodium because the cell for survival it needs sodium. So it will take sodium from the interstitium here. If you see this pump here below, that will take cell from interstitium in exchange of calcium. Understood? So whenever there is no sodium absorption, the cell requires sodium for the survival. So it will take sodium from the interstitium. Okay. In return, it will take the calcium out from the cell into interstitium. So it will create a lacking of calcium in the cell. It helps in absorption of the calcium in the cell. So there is more and more calcium absorption. More calcium absorption. Because there is more and more calcium absorption, your urinary calcium is very less. Urinary calcium is very less. I hope it's clear. Okay. So let me explain again one more thing. So if there is no sodium absorption, if there is no sodium chloride pump, there is no sodium. If there is no sodium in the cell, you will have hyponatremia. Clear? If there is no sodium in the cell has to survive. It will take sodium from the outside interstitium in exchange of calcium. So your calcium is getting absorbed more from the lumen for the exchange of sodium. Right? Because this calcium is more and more absorbed, you will have urinary calcium as less, very less. That's it. This is the only difference between gentleman and barter. So gentleman has urinary calcium low and barter has urinary calcium high. Clear? I think it's clear. Right? Okay. Then comes here, this is the other thing. Right. This is a collecting duct. Here, this is your medullopodgate, aldosterone. This aldosterone acting on the receptor. And this is producing sodium absorption through what is called as ENaC channels, epithelial sodium channels. Now in Liddle syndrome, what is going to happen? Liddle syndrome, there is positive stimulation of ENaC channels. Stimulation of ENaC channels. If there is stimulation of ENaC channels, what is going to happen? Your sodium is absorbed more and more. Okay. Similarly, potassium is excreted more and more. So you'll have hyponatremia. Sorry. You'll have hypernatremia, hypertension, and hypokalemia. Okay. And you have metabolic alkalosis. Because it is the one which is generating bicarbonate, bicarbonate is also getting absorbed. So metabolic alkalosis. Okay. So what is going to happen in Liddle syndrome? More and more sodium channel, ENaC channels are stimulated. Because ENaC channels are stimulated, more amount of sodium is absorbed, you will have hypertension. Okay. And potassium is getting exceeded, hypokalemia, and you have metabolic alkalosis because bicarbonate also getting reclaimed from the intercalated cells. Okay. But because of hypertension, because of more and more sodium, your RAS is getting inhibited. Okay, so that's why your aldosterone is inhibited. Okay, then what you can say is, if you see these three things, it is hyperaldosteronism, like that only. Hypertension is there, hypokalemia is there, metabolic alkalosis is there. It's a hyperaldosteronism, but aldosterone is low, so that's why it is called as pseudo hyperaldosteronism. I think accepted, right? Clear? That's it. So these are three symptoms you have to know: Bartter, Gentleman, and Gordon. So Bartter syndrome, please, very important. Okay, there is hyponatremia, hypocalcemia is there because calcium is not getting absorbed, right? So urinary calcium is very high. Similarly, in Gentleman syndrome, the urinary calcium is very low because it's getting absorbed more. In Liddle syndrome, because of more amount of ENaC channels, so more sodium, hypertension, hypokalemia, and also aldosterone is but low. It's called pseudo hyperaldosteronism. Clear? So now thing is, see this thing, what is they are asking here? Patient has hypokalemia. Wait a minute. Okay. Patient hypokalemia, metabolic alkalosis, hypomagnesemia, hypocalcemia, hypercalciuria. Where you see hypercalciuria? Where you see urinary calcium more? You can see only one thing, that is your Bartter syndrome. That's the Bartter syndrome. That is the only thing. Urinary calcium is more. Okay. So the question is, urinary calcium is more. Your syndrome is Bartter syndrome. Okay. Clear? So please remember these tubular disorders. So only these 3 points are important. If these 3 points, if you know, then all this mechanism and all you can easily conceptualize and you can write. Only thing is what is autosomal recessive, what is autosomal dominant, which is thick as an enzyme, which is thin as an enzyme, where is sodium potassium chloride pump, which is one acting on sodium chloride, what is gain of function, what is loss of function mutation. That's it. These 3 are very important points. After this, everything is a conceptual thing. Right? Clear? Right. Let us go to the last question. If anyone answers this question, is a very good thing. Let us see this question. This is recent last NEET SS question, very important thing. And why this question is very important also, I'll explain to you. So let us see this thing. Now a patient presents long-standing fever, persistent cough, and progressive weight loss. Fever, cough, and weight loss. Fever, cough, and weight loss. Okay, imaging of chest shows bilateral infiltrated cavitated lesion. Usually think of tuberculosis. Raising any suspicion tuberculosis only, yes. However, sputum examination demonstrates gram-negative bacilli with characteristic bipolar appearance. Which of the following is the most appropriate treatment? So, what is the disease here? Anyone knows here? Yes, right. The disease is here is melioidosis. Very important. Melioidosis. The disease discussing is your melioidosis. Right. So, melioidosis organism is your Burkholderia pseudomyelli. Burkholderia pseudomyelli. Okay. So, what is the take-home message is melioidosis is one infection which usually presents like a tuberculosis. Okay. It is a long-standing fever, persistent cough, cavitated lesion. But when you do gene Nielsen staining, it won't reveal any acid-fast bacilli. It will reveal gram-negative bacilli, and that bacillus is in Burkholderia pseudomyelli, which is disease called as melioidosis. Okay, so let us discuss about this topic once very easily. So let us see Burkholderia. Very important hot topic. Okay, in Burkholderia you have 3 things. One is Burkholderia cepacia, Burkholderia pseudomyelli, and Burkholderia melli. Okay, Burkholderia cepacia you see in case of cystic fibrosis. Okay, just simple pediatric disease. They won't ask for adults. Burkholder pseudomyelitis has melioidosis, and Burkholder pseudomyelitis glanders disease, just a glanders disease. Simple. Just remember the name. That much is enough. Okay. Let us see what is going to happen here. This Burkholder pseudomyelitis. Okay, very important here. It always grow in soil and water. That means whenever there is a contaminant water, whenever there is a contaminant soil because of some because some drainage environment is contaminated, then you will have infection. And any person who is going on a barefoot individuals, then only this inoculation will happen. Very important. Okay, it's a gram-negative bacilli. It's a gram-negative bacilli. Okay, it causes 3 diseases. One, it will cause septicemia. Okay, whenever it enters into the body, it will cause septicemia, disseminated septicemia it will cause. Or second thing is, it will cause what is called as pneumonia. This pneumonia is acute or chronic, usual presence like a TB, tuberculosis. And other is very, very important, abscess, multiple abscess. Okay, taking a patient has liver abscess, patient has splenic abscess, patient has prostatic abscess, and other is what is called as septic arthritis. These are the 4 different presentations of Burkholder pseudomyelitis. Okay, the patient can have melioidosis in any of the form, either septicemia or melioidosis pneumonia or melioidosis abscess or septic arthritis. Okay, of any knee joints. Okay, so this is very important. So what I want to say is, if any patient has pneumonia which is resembles TB but Jadenstein is negative, if gram-negative showing some gram-negative bacilli, please remember you have to treat about melioidosis. Okay, or if patient has an abscess, is a splenic abscess, prostate abscess, liver abscess, anything, please think of Burkholder. Please put in your mind. And if this patient has a septic arthritis, please think of pseudomyelitis also. Okay, so what is the treatment here? This treatment includes 2 things, very important here. Why is only 3 drugs are used for the Burkholder? One is meropenem, ceftazidime, and cotrimoxazole. This is Cetron. Okay, so treatment includes induction phase and maintenance phase. Treatment is induction phase and maintenance phase. Okay, induction phase you have to give either meropenem or ceftazidime for 2 weeks. Very important. Then maintenance phase you have to give Cetron, sulfamethoxazole, that is about 3 months. Very, very important. 3 months. Extensive treatment, because it's a facultative intracellular organism. So it is, you have to extensively give for 3 months. Yeah. So these are extra points for the melioidosis. Very important thing, because they just asked about this thing. They will discuss about this thing. So one more important thing here. We see the image. This is the safety pin. So colonies are like safety pin. So this is safety pin appearance. Okay. If you see colonies here, the safety pin colonies. Okay, safety pin. Right. So let us see the question. The patient has a gram-negative bipolar safety pin staining. So it's a melioidosis. Which of the following is most appropriate? Ceftazidime followed by cotrimoxazole. Okay. Amphotericin B, it's an antifungal. We are not giving this thing. Streptococcus doxycycline is a brucellin. Are not giving this thing. Rifampicin also not giving this thing. So answer is ceftazidime plus followed by cotrimoxazole. Very important. Melioidosis is a hot topic, because in Andhra state, in Guntur district, this melioidosis endemic has happened just 6 months back. That's why they're again starting to ask this question. Right. Any doubts in this melioidosis? Very important. This to be definitely they can ask this question again and again. Right, so this completes our 10 questions. This is our demo class. So what I'm telling you is, so we are going in the same pace. We're taking on some system. We'll take on some system, neuro or cardiology definitely. So after that we'll divide into topic wise, and each topic will write the questions and all, and each question will discuss, just not like a question. So how to go in a different approach. It's not a theory class. It's not any extensive class. I don't want to dump so much of information on you people. I just give whatever information is needed for you people, so that it is easy for you to remember and apply and write exam. NEET SS is not a complicated exam, it's just a clinical based exam. And how to deal clinically, how to approach the answers, I will deal in the class. Right? So we'll stop the class here. Any doubts, you can message me, you can talk to us, and we can meet in the other class. Right? Any doubts you can discuss, otherwise we'll stop the class here.